Okay, class. This will be the last sort of, I guess, materials video that I'm gonna be doing for the semester. So this one's gonna be a little bit longer because I'm gonna cover the last two articles. So you get a 2-for-1 here. And I'll do a separate video a little bit later to cover some of the questions that you asked about this first article, the Lloyd Richardson article. And then Tuesday we will have Ask Me Almost Anything, and that'll be a wrap. So again, this video is going to be a little bit longer, but I'll try to get through this material fairly quickly. And so we're going to talk about non-suicidal self-injury. And as discussed in the Lloyd Richardson article, we define non-suicidal self-injury, or NSSI, which is less of a mouthful, as the intentional destruction of body tissue without suicidal intent and for the purposes that are not socially sanctioned. So things like tattoos or piercings would not be considered to be an SSI. Now, there's a little controversy around this definition, particularly around the issue of intent, but I'll wait and we'll get to that a little bit later in the video. Rates do vary a bit depending on age group, with younger folks being more likely to be engaging in an SSI. Our best guess, fairly conservative guess, is about 15% of adolescents in the US. Some estimates have ranged as high as 46%. Adolescents in psychiatric settings, the rate is quite a bit higher, so 40 to 80% of adolescent psychiatric patients engage in NSSI. For adults, that number is about 3 to 5%, with 20% of adult psychiatric patients engaging in NSSI. The age of onset tends to be the middle school years or early high school, so 8th or 9th grade, although there is some variance there. I've seen it in kids as young as 8 or 9. Rates are similar across genders, which may come as a surprise to some people. I think NSSI tends to be associated more strongly with females, but in fact, males self-injure, but they tend to do it differently. And finally, in terms of race and ethnicity, white adolescents are quite a bit more likely to engage in an SSI than non-white adolescents. So how do people self-injure? It depends on who you're measuring in a large part. So in psychiatric samples, the NSSI tends to be more serious or severe or injurious. So psychiatric samples tend to use cutting or carving. In community samples, it tends to be scratching, which is a little bit more superficial in terms of the wound that the self-injury leaves. Females tend to use cutting and scratching. Males yet tend to use burning or hitting. So doing things like heating up a lighter and pressing it to the skin, or hitting themselves, or hitting a wall, or some other object, like punching a wall, punching a tree, things like that. But again, when you consider both of, even those behaviors are different, they're both considered forms of self-injury, and when you factor that in, the rates are roughly equal for males and females. Most individuals will use multiple methods as well. So you may cut and scratch or cut and burn, but only a minority go on to self-injure chronically. So it's for most self-injurers, it tends to be a fairly discrete period of time where it happens just a handful of times, and then they stop on their own. But some do go on to self-injure chronically, and as we'll see, that tends to be a risk factor for suicide. Where does self-injury occur on the body? Typically arms, but also thighs and stomach. So, and depending on the function of the self-injury, some may self-injure on the arms in a place that's readily visible, and others may have other motivating factors may self-injure in a place that's easier to conceal so nobody else sees them. Which gets us to kind of the next point here, and that's why do people self-injure? So the most common reason that self-injure site or adolescent self-injure site is emotional regulation. So either to distract from emotional pain, to release anger, or to relieve unpleasant thoughts and feelings. So those are a little bit different, but taken together, they're all forms of emotional regulation. Again, when we think about self-injury, we often talk about the function of it. What purpose does it serve? Because, the argument here is people engage in behaviors for reasons, even if those behaviors are destructive. So self-injury does accomplish something for the person who engages in it. And most commonly, that something is reducing stress of negative emotions or to relieve a feeling of numbness. Other reasons, response to a stressful event, and these are not mutually exclusive. So you can, experience a stressful event and feel very upset or distressed by it, and then self-injure as a result, and that might capture actually both of those categories. Evoking a feeling, reducing the numbness. I actually would say that's emotional regulation too, but different study criteria, so they treated this a little bit differently. So this is, for example, in depression, you may have heard of anhedonia, the inability to experience pleasure. Oftentimes when people are depressed, they report feeling the inability to feel much of anything, that they're just numb and sort of empty, and self-injury may reduce that feeling. Other common functions can be what we call social signaling. So it's sending a message to others that something is wrong. And only 2% reported that they self-injured because friends self-injured. Now, that might be a little bit of I would say, reporting pressure. Adolescents may not want to necessarily admit that they self-injure because other people do it. That may be a not such a good or not such a desirable answer. So I would suspect that that number might be a little higher in reality, but it's hard to tell. Characteristics of adolescents who self-injure: greater physiological distress and higher levels of emotional distress. So what I mean by this is they tend to be more physiological reactive in response to stress. So they may get more anxious, more amped up, more angry, more activated than non-self-injurers. Decreased distress tolerance, so inability to cope successfully with stress. Also lacking the skills to cope with stress. So, we have something of a set point in terms of the amount of distress we can naturally cope with successfully, but we can modify that by learning additional coping skills. And so self-injurers tend to have deficits in both of those areas. Also, difficulty with problem solving, so choosing more maladaptive solutions to problems, feeling less self-efficacy, meaning they feel like they have less impact or control over outcomes. Unlike suicidality, adolescents who self-injure do self-report more impulsivity. And this may look familiar from the suicide literature. 74% of adolescents act on the urge to self-injure less than 30 minutes after having it. So, going back to the Deisenhammer paper we read way back at the beginning of the semester, very similar kind of profile with self-injury as well. Depression is related to self-injury. That typically, it's one, if not the most common disorder we see accompanying self-injury in adolescence. It's certainly in the top couple. And also a history of abuse, and it's over 50%. And actually, older formulations or thoughts about self-injury might suggest that self-injury is the direct result of an abuse history, and people wouldn't self-injure if they didn't have an abuse history. That isn't true, but still there's a high rate of abuse among self-injurers. In terms of diagnoses, technically self-injury is only a symptom of one disorder, and that one disorder is bipolar personality, or excuse me, bipolar, borderline personality disorder. And so typically we don't diagnose that in any personality disorders in children unless there are some kind of weird circumstances. Hush. Oh, all right, apologies for the abrupt stop. We had a very loud dog who heard wind and raised hell. Back to psychiatric diagnoses. It's common in mood and anxiety disorders, particularly. Like I said, depression is probably the most common, particularly for adolescents. Other disorders where you may see an SSI, including eating disorders and substance use disorders. Those tend to be a bit rarer overall in comparison to mood and anxiety disorders. Again, childhood abuse, I already talked about that, so I'll repeat it here. And so the notion of self-injury contagion. There is some evidence that self-injurious behavior, that's what the SIB stands for, can appear in clusters within peer groups, suggesting that it can spread in adolescents that are previously unaware of self-injury. And we do encounter this in school systems, particularly with social media, of groups or peer groups posting pictures of their self-injury on social media and sharing with one another. And it does appear, at least outwardly, to be that sort of contagion kind of pattern. But despite this, researchers tend to agree that intrapersonal factors, internal factors, are stronger predictors and contributors to self-injury than interpersonal factors. And so probably the best way I've heard this said is that those who self-injure for interpersonal functions are a substantial minority. So it's not uncommon, but it's less than half. The studies do have limitations, as I mentioned. There might be some hesitancy to respond in a way that indicates that you're self-injuring for attention. It's probably not a real comfortable thing to do, or a real attractive option for those folks. So what we sometimes do is conduct create a sociogram to look at contagion factors. So sociogram is basically you plot out sort of connections between different people and relationships between different people, and then you check in with those different people who are connected to see if something's up and if they're self-injuring and they need help. One of the more interesting models of non-suicidal self-injury is the two-dimensional model. So this is Matthew Knock and Mitch Prinstein, who's at UNC. And the two dimensions are this: intrapersonal versus interpersonal. So is it done for intrapersonal reasons, or is it done because it's socially reinforcing? So intrapersonal means to create a more desirable internal state, either avoiding pain or to get a rush from the injury. The interpersonal or socially reinforcing pole would be a function to create a more desirable external state. So avoiding social responsibilities or signaling need for support. And then we have positive and negative reinforcement. So again, positive reinforcement is the addition of something desirable or that increases the frequency of a behavior, and negative reinforcement is removal of something undesirable or removal of something that that results in the increase in the frequency of behavior. So positive intrapersonal would be to get a rush. Negative intrapersonal would be to avoid emotional pain or distract from emotional pain. Positive social reinforcing would be to get perhaps sympathy or attention as a result. And then negative social reinforcing might be using self-injury to avoid something. So I've seen cases where kids will threaten their parents with self-injury, say, if they have to mow the lawn, right? Or if they have to attend some function. And so that's avoidance, and that's using self-injury as a negative social reinforcement. Treatment, as I've mentioned a couple times now, we like to talk about self-injury in terms of its function, and so not surprisingly, treatment focuses on the function. So understanding why an individual self-injures can help determine what would be effective. So the best practices for treating an SSI include CBT-based interventions, so cognitive behavioral therapy, as well as dialectical behavior therapy, DBT. And usually it's some combination of, first of all, not judging the person for their behavior, trying to not shame them or dissuade them, but really understand why they're engaging in self-injury, and treating them with unconditional positive regard, not judging them for it. It can be means reduction and monitoring. That can be part of it. That depends a little bit on the circumstance. Usually you don't want to do that until you give them something else to replace it, because you can actually make people worse, because if their only coping mechanism is self-injury and you take that away, you can really make a mess. What we tend to do is work on skills involving problem solving, emotion regulation, and distress tolerance. And you'll note those are all areas that I mentioned previously as deficits. So we're trying to address the kinds of deficits that make people vulnerable to self-injury. And so now I'm going to transition into talking about the relationship between non-suicidal self-injury and suicide. And I mentioned, well, before I get to that, they are very much related, but individuals, as was discussed to some degree in the Lloyd Richardson article, suicide attempts and self-injury are related, but those who do attempt suicide tend to have longer histories and a bigger number of methods they use for self-injury. So there's more self-injury episodes. There's not more episodes, but just a longer history over time. Some studies, interestingly, have found that suicide risk in self-injurers really starts to increase at something of a tipping point. Like, you don't have a lot of additional risk if you just have a few discrete episodes of self-injury. But once you hit around 20 episodes, your risk of attempting suicide goes way up. And so it's not a linear thing. You know, you have low risk, low risk, low risk. But once you kind of hit that 20 self-injury episodes, your risk starts to go up pretty steeply. But again, these things they commonly co-occur. And among adolescents who engage in self-injury, 70% have, one study found 70% had at least one suicide attempt. More than half, about 55%, had multiple attempts. almost 90% had some lifetime suicidal thoughts, and 20% had frequent suicidal thinking, either daily. And so this, think back to the Joiner book that we read earlier in the semester, is this partial support. So, with more episodes, does that mean we're developing fearlessness in terms of pain? So in that sense, it does look like it might be partial support for the interpersonal psychological theory that Joiner proposes. But there is some controversy. Some do argue that non-suicidal self-injury is misleading because it is so related to suicide, and some see this sort of self-injurious behavior to exist on a continuum, with suicide representing an extreme. So this gets into the notion of ambivalence, right? So what is the intent to die in self-injury? It could be 0, it could be 100%, right? So the argument goes, if non-suicidal self-injury and suicide were distinct from one another, what we might expect to see is this bimodal distribution, where you see one group of non-suicidal self-injuries with very low intent, and then another group over here of suicidal individuals with high intent. But that's not what the data bear out. So this is the distribution of people who have self-injured on, this is their scores on the Beck suicide intent scale. And as you can see, you don't get these two distinct groups. You don't get the low intent people and the high intent people. What you get is more of a continuum, that a lot of those people fall in the middle in terms of their intent to actually die. So between, say, 2 and 15 or so, 15 or 16, that's the majority of the people in there, and kind of that middle ground. And so there is ongoing debate on whether or not self-injury is just, is it a rehearsal? Is it a form of preparation for a later suicide attempt? Is there just ambivalence in terms of what the outcome is going to be, or what the intent is? I've had adolescents say, I did this thing and I didn't know what was going to happen. It was sort of like a roll of the dice. And if I ended up dead, then that's fine. And if I didn't, well, then it wasn't meant to be. That kind of attitude. And that's sort of what you might infer from this pattern of data. So the self-injury and the suicide are not easily distinguishable by intent. So it continues to be a controversy, and it continues to be somewhat difficult for us to really understand. So I thought what might be interesting would be to give you an actual case study that a self-injuring adolescent that I treated. And of course, I changed names and some minor details to protect the student's privacy. So we'll call the student Marcia. And so Marcia was a 16-year-old Caucasian female from an impoverished background. She started self-injuring her at age 13. And at the time she came to see us, she had one past suicide attempt. She was referred by a school counselor for a recent, that SI, sorry, I try to avoid this, but it ends up happening anyway. That means suicidal ideation. So it could be, SI is either self-injury or suicidal ideation, and apologies for the mix-up. This was, she was talking about suicide. She had a couple of really dramatically angry outbursts in class. Her teachers were really concerned about her appearance. She was really unkempt. She was she would wear dirty clothes to school. She looked like she hadn't showered, and then her behavior was just generally hostile. So Marsha was referred to us. We did the intake, which revealed significant symptoms of depression and really a lot of conflict in the home. Everybody fought. So mom and dad were fighting, the student and both parents would fight. Marsha had a sibling, they would fight. So everybody was fighting with everybody pretty much all the time. So it was a really dysfunctional kind of environment. Frequent suicidal ideation, but no plan or intent, no access to firearms or dangerous medications. And as is remarkably common with self-injurers, she had a very particular type of self-injury that she engaged in, and that was she would take razors out of the little pencil sharpeners that come with eyeliner, and she would unscrew those and use the razor from that pencil sharpener to cut. And she was cutting on average of 1 to 3 times per week, but hadn't cut in the 10 days prior to treatment. So based on that information, the first thing we wanted to do is figure out what the function of the cutting was. And what Marsha revealed is that it served 2 primary functions. First of which was relief of negative emotions. But there was also an element of self-punishment here that she would cut when she was disappointed in herself for something that she did, either something that happened at school or something that happened with friends, a fight that happened with families, that this was her way of sort of punishing herself for not doing better. And so typically we worked through what's called a chain analysis, where we look at the antecedents, the things that happened before the self-injury, and then also the consequences. So a typical kind of chain analysis for a self-injury episode for Marsha looks something like this. So there'd be family discord, there'd be a big fight, there'd be a big blow up in the house. As a result of that, she would withdraw. So she'd go to her room, slam the door, be very angry, very upset, and then feel worthless, like, not even my family loves me. I don't belong, and that would lead her to feel very angry, very depressed, and feeling like she had no alternative. And this is where the lack of coping skills comes in. That like the only thing she could see as being available to her, and that could relieve some of these intense negative emotions, would be self-injury. So that was important for us to know. So we got some traction there. So there was hope about starting treatment with us, and then also a parent who seemed very volatile had gone without medication for several months, and then got that medication refilled. It was a mood stabilizing medication. And once that parent got that medication refilled, it resulted in less discord in the home. So we had some things going for us naturally at the beginning of treatment that got us off on a pretty good foot. So we did a safety plan. So even though she had some suicidal ideation, but no plan or anything else, she was self-injuring. So we made kind of a safety plan that incorporated some elements involving self-injury as well. So not only what triggers suicidality, but also what triggers self-injury. We kind of weave those two together in our safety plans. We gave her a lockbox so she could lock up the blades that she was using, and she gave it to her sibling actually, and not her mom, because she revealed that her mom also self-injured. So there could be some modeling involved here that Marsha learned this coping technique actually from her mom. So knowing what we knew about the function, we went into giving her tools to replace those functions. So to back up just a second, relief of negative emotion and self-punishment. Those were really the two functions. And so we try to give her other things besides self-injury that might do that. So what we learned in working with her through a couple of sessions is that she didn't have a good sense of what emotions were. She had difficulty distinguishing between, for example, anger and sadness or hopelessness. And well, we started with mindfulness, and she really didn't like mindfulness. And that's not uncommon, particularly for adolescents. Mindfulness can be very difficult, particularly with someone who's very, emotionally dysregulated. Mindfulness can be very foreign, and it can even be kind of scary in some ways for people who are very distressed. And so we started with describing emotions. So getting her to distinguish between anger and sadness and helplessness. And the reason we do this is it assists with her ability to do some problem solving. If she labels emotions accurately, she can come up with a more appropriate response for that. We also did some DBT skills, involvement mostly focused on distress tolerance. So opposite action techniques is where you behave in a way that's opposite of how you actually feel emotionally. So if you're angry, you do something very nice to a person. And the idea here is when your behaviors don't match your emotions, your emotions tend to follow the behaviors, not vice versa. So act in the opposite way that your emotions are telling you to tends to drive those emotions down in terms of their intensity. Increasing the number of pleasant events that Marcia was engaging in was also another thing we did. She'd go home and inevitably get in a fight with someone. So we had her try to engage in different activities that would keep her out of that household conflict. So going for walks, reading, drawing, things like that. Also taught her about riding the waves. So the idea here is that strong emotions can't last forever. So they kind of come like a wave does, like they go up and then they come back down. And if you're ever swimming in the ocean and a wave comes up, it's much easier to go with the wave than try to swim against the wave and control it, right? And so that actually really resonated with her, and she used the riding the wave language pretty much for the rest of our treatment time together. We did some interpersonal effectiveness because of the discord in the home. So assertive communication, making requests, problem solving. So to try to bring the temperature down a little bit so that disagreements or even interactions didn't result in shouting matches, that we could get that under control a little bit quickly. And through these, we made it 6 weeks with no additional self-injury. But then in week 7, she came in with fairly severe self-injury. In fact, one of the more severe episodes of self-injury that I've seen personally. It's very, very deep cutting. And the thing I had to do in the moment was, not show disappointment, not remind her that she had made it this far and then had backslid, but instead explore the situation, the circumstances that led to her self-injury, non-judgmentally, and also with empathy and validation, and with understanding that this happens, and not punishing her further for something that she already felt guilty about. The wounds were such that she also needed medical attention at this point. So I actually took her down to the school nurse and got her cleaned up, which I didn't realize at the time. I mean, it was just a matter of something that I felt like was really necessary to do. But she took as a real signal that it really kind of built trust in me. that I took the time, that I was that concerned about her and her well-being, that I would take that extra step to get her medical attention, which, you know, again, wasn't something I thought was special, but for some reason it really impacted her and her trust in me. So after that, you know, I was like, okay, this happened. You know, let's review what we've done, and let's try to separate what worked from what didn't. And so we came up with some new tactics. So increasing family contact, really working on that withdrawal piece, revisiting some means reduction. Obviously, she had gotten some additional blades for this new episode. We looked at alternative behaviors. So rather than cutting oneself, sometimes we'll tell people to draw on themselves instead. And the thing that really kind of stuck was journaling, which is not something that we had tried previously. And, you know, so she had weekly journal assignments that were pretty loose, but they were structured in a way that we brought in topics covered in session. She would write about them and how they were going at home as she was using them. And as it turned out, she really enjoyed writing, which is something that I didn't discover until really we started doing it. From there, we tapered to, you know, that really worked. We went through probably 6 more weeks through journaling, you know, doing more pleasant activity scheduling, particularly with the family, which had, again, because of the parents' recent medication reintroduction, got a little bit more stable, and that became a source of strength rather than a source of discord. So it got to the point that we tapered to biweekly and then monthly. We finished the school year with 2 months of being injury-free, and I was able to follow up with the student the following year. And so she was a junior when we treated her. She made it her entire senior year, no self-injury, and graduated. So that for us was a really great success story. So I just wanted to give this, as this was a rather complicated case, but this isn't atypical of the kinds of treatments you would do with someone, with an adolescent who self-injures. So just kind of you know, a peek behind the curtain in terms of what a clinician might actually do with one of these cases. So I'm going to stop with this finally. So in some non-suicidal self-injury, it's complicated, it's scary, it's important, and there's a lot more that we need to do to understand it and how it's differentiated or not from suicidality. Is it a continuum, suicidality and self-injury, or are they two qualitatively different things? I think that's a question that still has not been answered with any real confidence. So I'll leave it there, and I'll post another video a little bit later, taking your questions about this stuff. So see you then.